I think people are afraid of Neratinib. I think that people fear the diarrhea. And it's interesting to note in this trial, in the NALA trial, while the incidence of grade 3 diarrhea, which is more than 7 stools a day, was about 24%, it turns out that the mean time of grade 3 diarrhea was only 4 days. And the reason it was so short is that everybody had prophylaxis. So you had prophylaxis with loperamide, and there was a very specific schedule that they took. So with that intensive prophylaxis, the length of grade 3 was very short. And more importantly, only 2.6% of the patients on the NALA trial in the Neratinib arm discontinued therapy because of diarrhea. So it's very manageable. So given the fact that I think that this irreversible binder of HER2, significantly improves progression-free survival, has a trend toward overall survival, reduces the incidence of intervention for symptomatic brain mets, has a higher duration of response, and has manageable toxicity in a randomized phase 3 trial, I think this could be one of several standards of care that we now have for this disease. The question is, does the management differ in the relapse setting as it would, say, in the extended adjuvant setting? The answer is no. The key is here to use intensive prophylaxis, is to use loperamide, is to use dose reduction when needed, or dose escalation. I think that's the newest strategy. We have a lot of strategies that we're employing, potentially cholesterol, potentially budesonide. And it usually tachyphylaxis within a month. But again, I think you look at the data. The data is that, yes, people can get grade 3 diarrhea, but the mean time that it lasts is 4 days. It's done. And that's kind of, people don't realize that. They think, oh, you're going to have grade 3 diarrhea. grade 3 diarrhea. They're going to have grade 3 diarrhea forever. The whole time you're on it, you're going to be miserable. And that's the rep that the drug has, and that's simply not true. The clinical trials data shows that, again, with a combination of a variety of strategies, fairly intensive prophylaxis for the first couple of weeks, people generally do well. And we have other drugs like this. Abemaciclib now is another drug that has a lot of diarrhea up front. We manage it, because now we have evidence that these drugs work. And it's worth it to go through a couple weeks of this to get them through it. Then it should be fine after that, generally. Obviously, there are people who are going to have issues no matter what, but in my experience and the experience from the trials is that this grade 3 episode is fairly limited, and usually is within that first month. It's no more than a couple, 4 to 5 days, and then you're done. It turns out that in the clinical trials, the original clinical trials with no prophylaxis, the incidence of grade 3 diarrhea was like 40%. When we started using intensive loperamide prophylaxis, basically TID for a week or two, and then BID for a week or two, then QD for a week or two, and then off, that went down to about 24%, grade 3. It turns out there's even more intensive ways of doing it. So cholesterol, anti-cholesterol drug, a bile acid sequestrant, lowers the incidence of grade 3 diarrhea, I think, to about, if I'm not mistaken, probably in the teens. Budesonide, which is an oral steroid used in Crohn's disease, ulcerative colitis, inflammatory bowel disease, that lowers it to the mid-teens as well. The newest strategy that we're employing in the control trial, which is a trial trying all these strategies, in the control trial we're using a dose escalation, so we're starting at 160, so 4 pills a day, 160 milligrams a day, and gradually escalating it with loperamide prophylaxis. And I think that's going to actually probably be a very effective strategy as well. Because it turns out people who've been dose de-escalated in the clinical trials do just as well as those that start at 240. So their clinical benefit, at least in extended adjuvant therapy, looks to be as good. And so I think that what I'm doing is a combination of everything at some point. That's where I'm going to. When the trials lead us there, it's probably going to be dose escalation starting at 160, gradually increasing, and including either loperamide or budesonide with loperamide. Again, for the first month. I think once you get through the first month, you should be okay. So how do patients manage nausea? There's a lot of things people do that are less than, using, things like, ondansetron and palositron and things like that, and, and compazine. I think that ginger, sour things, eating frequent small meals generally helps. In terms of the diarrhea, it's kind of like we say the bland diet, the brat diet, bland sort of things, bananas, that sort of thing for a while. In terms of fatigue, I think the most important thing that's come out is just trying to get yourself up and just move around. Exercise, I think, for fatigue is one of the biggest things you could do. And then you don't have to go crazy. Just go for a walk around the block or something. Just do a little more than you have been doing. and that can tend to help the fatigue. When I used agents like this, I mean, the incidence of LFT abnormalities with these drugs is small, but I tend to monitor LFTs every other cycle, probably. So, you know, if it's a 3-week cycle, you know, I probably would end up doing it probably every 6 weeks or so, 6 to 9 weeks, especially someone that has liver metastases. Someone has liver metastases, they'll probably get it probably almost every 3 weeks, at least for a while. You know, and then if their liver disease is stable, you know, and the liver abnormalities kind of normalize, you know, probably be every 3 months or so.